welcome everybody to this webinar. It's basically set up by the British Computer Society Primary Healthcare Specialist Group, of which I'm the chair. I'm Miriam Lamar, and I'm very grateful to Minal and Dominic for coming along today. I thought I would quickly start by telling you a little bit about the British Computer Society while everybody is coming in, for those who don't know about it. And so if I do that, sorry about all the M's and R's, I'm also trying to admit everybody at the same time. So for those who haven't heard of it, the British Computer Society was founded in 1957. It's the Chartered Institute for IT. There's 60,000 members across 150 countries, and its purpose is about making IT good for society. And I suspect there are a number of people on here today who are members already. But it does things like the specialist groups who look at cybersecurity, look at digital divide is one that I've recently come across and I'm getting involved with. There's people who look at the legal side of IT as well, and it's open to all sorts of people from all parts of the IT sphere, including all of us from the Primary Healthcare Specialist Group. So the Primary Healthcare Specialist Group, which was founded in 1980, so it's going nearly as long as the British Computer Society. And it was founded by a lot of people who were heavily involved in the beginning of IT and digital within primary care. And some of them are still involved and have a lot of experience that they'd be very keen to share. So our membership covers GPs, suppliers, analysts, practice managers, you name it. We've got a lot of people within the group. And a lot of experience that we'd like to share. We're related to the Faculty of Clinical Informatics, which I guess some of you will possibly be members of, and we're seen as the primary healthcare group of the faculty. So our aim is about making IT good for primary care, which is one of the reasons why we've asked Minal and Dominic to come along today. And if I just quickly to give you an indication of the sort of things that we do, here we go. Sorry, also admitting this chap. So it's about, hopefully you can read that. I've just realized it's a bit small. So we like to raise awareness of things that are happening, like good practice, which hopefully today's webinar will actually achieve. We run an education day, a free education day annually, and a conference. And that's usually at the moment in November. So that's something we're in the process of developing. The education day is sort of more practical. What are the issues that people are tackling within practice at the moment or within PCNs? And the conference is more about looking to the future and finding out what people are doing about research, AI, decision support, some of those other things. We do quite a lot around prizes. So we've got an early career prize to encourage people who are new or early in their informatics, IT type career. And we've got the John Perry Prize named after John Perry. The example from this year was we had a young man who may be on the call here today, who won for some of the work he's been doing around robotic process automation in primary care. And the John Perry Prize was won by a team that have been looking at how you use data to use machine learning to actually identify and prioritize your asthma patients for recall. So some interesting stuff there. So we also, one of our missions is around encouraging people who are new into IT. So maybe there might be clinicians as an example, but are starting to move into a technical role, or there could be somebody within a practice manager. Then we've got an early career prize, as I mentioned, but also we've got some travel bursaries that we issue as well, and we'll be advertising those soon. I think that's to get people to go to things like MIE, which is in Gothenburg at the end of May, is the one that we'll be doing this year. So we represent primary care on different fora, and we've got a seat on the joint GPIT group. We comment on policy, and we run special interest groups where people will get together to discuss a particularly thorny topic. So just to give you an idea of some of the things that we actually get up to. So we're very active, and one of the things we want to do is tell people about what we do. So John, perhaps we could put the poll up, because what we'd like to do is to understand how you heard about this particular webinar today, because that will help us to let people know about some of the things that we're doing. For example, the travel bursaries, will be advertising those fairly soon. So we are very grateful for that piece of feedback. And while you're doing that, if I, oh, sorry, sorry, Minal. I was about to just introduce, I'm very, very grateful to Minal and Dominic for coming along today. I think this is going to be an absolutely fascinating presentation. It's something that's quite dear to my own heart. And I think there's a real opportunity within this. So Minal, I'm sure, is well known to a lot of you. She's the Director of Transformation in Primary Care Transformation in NHSE. She was awarded an MBE at Christmas, which I think is a fantastic award, and congratulations to her for that. And she's also a practicing GP in North London. And Dominic is working with Minal and is the UX lead, the user experience lead, I should say, and not user TLA, for within NHSE as well. So if I hand over to Minal to start, and then I think we can stop the poll, and I will stop sharing. Is that okay?
Thank you, Miriam.
Oh, one thing I should probably say while Dom is getting the polls up, we are recording this. And we will, so we'll make the recording available, and the slides, etc., will be issued after the webinar as well.
Great, thank you so much, and thank you for having us and inviting us along. And I've seen loads of familiar names entering the room while you've been talking, so really touched that some of the digital clinical leads and colleagues that I work with at NHS, well, now NHS England, are on the call too. So yeah, not daunting at all when you've got friends on the call. But yes, lovely to be here. And Dom and I wanted to talk to you, or really share with you what we've been doing to try and really progress improvements in the digital journey for both patients and practice staff. And in particular, thinking about how we improve the digital experience. So I think we are all probably very well versed with the challenges, the current challenges in primary care. But I think it is often worth just reflecting for a couple of minutes on the numbers, because every time I hear them, they are a stark reminder of how much we do in general practice and the challenges that we face. So there has been a 15% increase in clinical consultations undertaken in general practice since the pandemic. And this doesn't include all of the administrative work that we do in general practice as GPs and other clinical colleagues. And while everybody is feeling the pressure and everyone you speak to is really busy, there are some practices that are at the edge of chaos. And I was one of those practices actually pre-pandemic. We were at sustained crisis point. And the data also reflects this. So the data shows that demand is unequally distributed and that consultation rates are higher in practices, within practices that are based in highly deprived areas. And we know that pre-pandemic, the evidence showed us loud and clearly that there was increased need in those deprived areas. So 10% more need with 7% less funding. However, the pandemic has exacerbated these pre-existing inequalities. And what we see now is the rate of increase in consultations, i.e. our ability to respond to the increasing demand, is actually higher in the least deprived areas compared to the most. And that's not because, obviously, we know that that's not because need is greater in more affluent areas, but it's because general practice, particularly in deprived areas, cannot stretch anymore. We're already stretched to capacity, and this is a significant risk to sustainability. And so effectively what we're seeing is a narrowing in the relative differences between deprivation quintiles and potential widening of inequalities, which is why the work that we do is so urgent, it needs immediate action. And of course, to add to these pressures, we know that we've got lots of workforce challenges. So there's been a 3.3% reduction in full-time equivalent GPs since 2019. Over the last 7 to 8 years, GP partner numbers have gone down by a third, 24% of practices have closed, and particularly the impact has been felt again in the most deprived areas. And on average, practices in the most deprived areas manage 1,000 more patients per GP partner than affluent practices. So not only have we got an inequality in demand, but we've also got an inequality in the workforce that's spreading. And the Health Foundation have modelled what the workforce model might look like in the next few years. And if we were to do nothing more than we are doing now, we will have 1 in 4 GP posts vacant in 10 years' time. And so I think then it doesn't come as any surprise to any of us working in general practice that there has been a fall in patient satisfaction. And when you delve a bit deeper into the data, the patient satisfaction data, 80% of this fall in satisfaction is related to contact. And I think that's really important to remember. So the experience of the quality of care that people are still receiving from their practice remains high. And I think that's a real testament to the hard work of all our colleagues. But contact is the issue. And so I think in order for us to be able to maintain the core functions that we all hold very dearly to us as part of general practice, then we have to start changing our model of care delivery. And that was accelerated during the pandemic. So we are embedding more sophisticated navigation and triage processes so that patients can be managed by the right person or service first time. And that can mean we can design for better continuity, particularly for those that need it, more equitable and safer care as it's prioritised based on need. We can understand what's waiting in the queue. We are using our wider multi-professional workforce, so having appropriates that are distributed more appropriately to the expertise within our team, optimising use of that wider range of skills to support the quality and comprehensiveness of care that we deliver. And we have more flexible ways to respond to patient needs, particularly modality of consultations, the telephone, online, video, face-to-face, recognising that there isn't one size fits all. And we have been trying to improve access. So we have a more multimodal approach in the way that patients can access us now using online consultation systems. And what we saw during the pandemic was an absolute acceleration in the use of online consultation systems, doubling from about 1.2 million to 2.4 million. Use of the NHS app significantly increased. Patients were using the practice website to access services. 60% of patients from the National GP Patient Survey said that they try to access their practice through their practice website. And so we're absolutely seeing the use of digital tools becoming mainstream as part of delivery of healthcare, or access and delivery of healthcare in primary care, and in particular the use of digital triage tools to gather information up front so that we can start to prioritise care more effectively and better match our demand to our capacity. And a key part of that is then going to be enabling patients to use digital tools to start to complete some of those more transactional administrative tasks independently, such as ordering their repeat prescriptions, checking their test results, managing their appointments online. And this can have a big impact on phone calls. And I say this because in my own practice, we did an audit. We looked at all of the contacts that came through into our practice over a 2-week period. And over 80% of our calls about test results were about normal results, for which a significant proportion of patients could be managed online to ease pressure on the phones and reduce burden on our admin staff. And we estimated it could free up 15 hours of our admin staff time to then focus on more role appropriate work. So there are some big opportunities with actually some relatively simple solutions if we can embrace them and design them well. But what this also means is that model has become much more complex, and it's much more difficult for patients to understand and navigate. So to enable this to happen, to make the change easier, we need to have the tools and provide the tools to our patients that can enhance the impact and mean that the tools, and this means that the tools need to be accessible, easy to use and navigate. So we're starting with the digital front door, because that's obviously a very good place to start. And what we are aiming for are great user experiences. And what we see is that good user experience is now commonplace. And it's not just a good user experience from global American organizations, but actually there is some really great digital experiences that have been created by other parts of the UK public sector. So it can be done. And so primary care needs to think about patient needs across a lifetime and to design and test patient experiences against those patient needs. So we're looking for well-designed and tested digital experiences that make the complex simple, make them usable and accessible for the majority of the population. And so really our call to action today is that we need your help. This needs all of us to embed a culture of doing things differently and to create a great experience of digital access to general practice. We need to start reducing the complexity in our digital journeys. We need to improve integration. We need to provide support to staff and patients. That's a big part of the transformation, that change management approach. We need to deliver a consistent experience, and we need to use a test to ensure that digital journeys and tools are highly accessible and usable. And we need to embed that continuous improvement approach so that we have the capability, the culture, and the capacity to test, iterate, learn, and improve. And of course, wrapping around all of this is communications. So we also need to be able to communicate these changes to the public, but also to support other members of the system, the wider system, to understand the changes in general practice and in primary care. So I'm going to hand over to Dom now to share our very practical user research findings with you and some key principles, which would be great to get your feedback on around what we have found really helps to deliver a great digital experience that then can be applied more broadly across the digital journeys, the core digital journeys for patients. So Dom, over to you.
Brilliant, thanks Minal. The work that we've done really is looking at the reasons why people visit GP websites and what makes a good experience. And we've done that process with a large number of patients from across England. But it's worth noting that we focus in particular on the third of the population who are least digitally confident, and the understanding obviously being if we can make the journeys work really well for them, it's going to be a great experience for the vast majority of the population. So to set it in that context. So when we're testing, we always test with patients and a very diverse range of people within that third of the population. The really good news, I suppose, is our task is simple in some ways. There are only 5 to 7, depending on how you sort of classify them, things that really matter to patients. So when they're visiting a GP website, the bulk of traffic to most practices that we've seen data for, so sort of 80, sometimes even 90% of traffic comes to do these tasks. Patients are very task focused. They want to get something done, and it's all the obvious things that sort of spring to mind. So making, changing, cancelling appointments, which would include completing an online consultation form, ordering repeat prescriptions, getting test results, and checking opening times and contact details for the practice. So I think the really good news, if you want to take away one thing from today, is if we can get those things right, we will radically improve the experience for lots of patients, the vast majority of patients who come to the practice. So, but it's really doubling down and focusing on those core journeys. And what we did then in the testing was really quite straightforward. We asked them to show us how they would do their tasks. So what we call task-based testing in digital design work. It's very straightforward, it's observational, and we really look at the challenges or not that people have, the ease of use that people have moving through the stages of the journey and how they go about achieving those tasks. And that's what I'm going to talk about today. So we tested the 10 main GP supplier templates, which we believe cover about 90% of usage across England at the moment. And what they told us and what we observed was that many of our patients within this cohort are really struggling to find and start these key tasks that we've just talked about. You can see the sort of chart here with the 10 different templates, and the red, orange and green really indicate the sort of challenge or level of challenge that patients had doing those particular tasks. So red are where the tasks were completely abandoned. Obviously, that's the worst outcome for us. All patients found the incorrect destination or the incorrect place or incorrect piece of information. Obviously, amber is where they've struggled. So they have managed to do that. Sometimes that's because people click in and out of areas and a sort of lucky dip approach, and hopefully they might trip over the right thing almost by accident, but it's not an intuitive journey for the people undertaking that. And then green is obviously where we'd really like to be, and that's where people are. It's very intuitive, the structure, the layout, the wording that they're seeing in front of them, and therefore they can move really confidently, you know, at very different speeds, but they can move confidently to the things that they want to achieve. And I think the thing to note from this is really powerful is the difference between the best performing template and the poorest performing template, but all templates have some abandoned journeys, uncompleted journeys. So there's room for improvement for all of the suppliers, and we've been working hard with them, of which more later. And sometimes that obstacles can start really from the first step in the journey. So I've pulled out a few examples to show you, but the first example on the left hand side here is where we've got these dreaded overlays, these pop-ups, which to me take me back to the sort of 90s and the early internet, where things are sort of like springing up at you all over the place. Generally speaking, they're a real obstacle for many users, but particularly users of accessibility software, and also particularly on mobile, where they can occupy the entire screen. So we strongly recommend removing those wherever possible, and not designing them into future products. They are a real headache, and some of our users don't get beyond this page. They don't land actually on the homepage because they confuse the overlay for the actual homepage. And you can see an example here in the middle of where, you know, another overlay is then popping up not just on a single page on the rival page for most people through the homepage, but across every single page on a website. So your journey is disrupted in every single place that you come. And then a more subtle version in this third version, where the sort of icon, which actually triggers a really important piece of functionality, it's the online consultation form, obscures the functionality that sits underneath it. So if you want to access that, you can't actually get to it because the piece floats across it. The good news is all of this is solvable. You can see on the far right hand side, the NHS design standards and the digital service manual are excellent and have thought through many of these different scenarios and produced really great guidance and practical components that developers can embed into their website. And so the general recommendation, rather than pop-outs, is to embed all kinds of information, including warnings or call-outs within the actual structure of the page. And in this case, if it's an emergency call-out, to follow the NHS's recommended visual style, which is to call those out in yellow. So the good news is it's a very easy problem to fix, but it causes a huge amount of challenge for participants when we test with them. So once they've got to their landing page, really what's interesting is the mental model that people come trying to achieve those tasks. There's sort of a very consistent mental model and the language that goes with that. So people have a keyword usually in mind that they scan the page for, and this is really important, is how do we reflect the language that people actually use and have in their head. And it won't surprise you, as you can see on screen, when you're changing or cancelling an appointment, the keyword you're looking for on the page is something to do with appointments, the same with prescriptions, the same with sick note, same with test results, and then to either register or join if you want to join as a new patient. But those keywords are really essential. They are the thing that people are hunting across the page for. But they do that in sort of three different ways. And so when you think about the keywords and then the different ways that they approach, you have a really complete picture of that behavior. So the first is they scan the homepage, looking for those keywords that we just mentioned. So they're running down the sort of homepage and looking where that might be in a homepage quick link. On the homepage, there might be key tasks pulled out at the top of the page or top of the scroll on mobile. They then might start to look in primary navigation. That's usually a secondary activity, particularly if the navigation is hidden. So if you're in a desktop view and you've got something that says appointments, prescriptions, contact us, people will go straight to that. If it's hidden in a mobile view like this behind the dreaded hamburger menu, which I'll come to in a second, they have to open that. So it's a second task, and then they're scanning that sort of navigation, that submenu for the same keywords. And then the third way that people then try and find the things that they want is then looking at search. And then obviously one of the really key things is, am I using that key term to search with, and does it return a relevant result, or does it return a relevant result right at the top of a long list of results? And that's really key for people being able to use those things. So it's, how do I consistently find those keywords all the way in every step of the journey that takes me to the thing that I need to do? So just to turn to many, I've been testing digital things for about 15-20 years, and in all of that time I've never known anybody understand what this hamburger menu means. It's sort of beloved of designers because it's neat and tidy, and then if you're not quite sure, it's that sort of 3 lines in the square box there on the left-hand illustration. That's the hamburger menu. It's a really terrible piece of design, because the vast majority of people don't know what it means and don't know what it does, and therefore they don't know what lies behind it. And what that means is people then ignore it. And that's a really valuable tool, because that's access in mobile, particularly to primary navigation. And as you can see here, that's also situated alongside the search bar. Again, both really small, up in the top right-hand corner. Sometimes that will then just zip off the minute you touch a mobile screen and disappear off into the ether to be forgotten about. But what that means is, for users, and particularly I want to come back to the point around people who have moderate to low digital confidence, that means they've suddenly lost 2 other ways that they might be able to find the things that they want. And that's a really, that really handicaps people in terms of the ability to then use every tool and to explore in all the different ways that they need to, and restricts people's ability to achieve those things. And as you can see on the right, there's 2 slightly different versions that pull out different things. Is one, the open search box, so it invites you to actually put in key terms and to use that particular tool, and then the menu, both labeled as a menu or as an open menu, as you can see on the sort of right hand side here in the NHS mobile version of the NHS UK site. Again, it all prompts you and really supports users in terms of understanding what those tools can do, and if possible, if we know what their intent is, we can pull out some of the most important things for them. So in a GP practice, this could say appointments and prescriptions rather than health A to Z or NHS services. Then it becomes really effortless for a lot of people then to follow that trail. So there's a couple of examples here of where that doesn't work. So that first page, as I say, that's literally an overlay filling the entire screen of a mobile, and most people, when we tested, missed that sort of cross up in the top right hand corner. So for some people, that's where their journey ended. They couldn't get beyond that point. They thought that was the home page. We've talked about the challenge of the icon here, and then the third one, I think, is something we see quite a lot of, is you have a particular section here which is, who do I see? And then within that there's a list of symptoms, I think somewhere between 70 and 90 symptoms. So we'll come to that in a second, but it's a huge long list of symptoms, and I defy anybody to then scroll quickly through that list and find the one actual other task that's not related to those symptoms, which I've highlighted there, the sick note, fit note piece. So this is like playing hunt the needle in the haystack for most of the users, and almost nobody then reached that piece of information, because it's both in a section that's headed in a peculiar way, and then it's buried in the middle of a very long list. So that is the equivalent of digitally hiding that particular functionality. So how we label things, how we structure things, how many things are in a list is really important to lots of users, and being able to navigate that. And that sort of ties together with a really important piece that I'd really like to kind of draw people's attention to, because the suppliers can do some good work to help improve the template and the structure of the sites, and definitely please do ask them for all that help and ask them if they've tested them and they are as modern as they can be. But the challenge is also the other half of the equation, which is the content that's then loaded into those pages. And so there's a really strong overlap between lower digital confidence and literacy challenges, and that runs across a huge swathe of the adult population, up to between 7 and 11 million people, as you can see on screen. So it's a huge challenge, and it's when we talk to practices, this comes up a huge amount in the challenge of trying to support patients to access and use these services confidently. And unfortunately, when they hit a kind of piece like this 1,000-word essay on how to create an appointment, there's kind of a couple of challenges. It's one, it's just overwhelming because it's so long. There are literally so many words in this. It's like War and Peace for people. But I can't describe to you. I wish I could introduce you to some of the people that we've seen in testing where this is like the worst day at school. It makes you feel unbelievably stupid because you cannot navigate this amount of text. You cannot absorb it. You can't read it. It's not very well structured. So it's not just this is hard to navigate, but it produces extremely strong emotions in some of the people that we test with. And so writing really clear, well-structured, brief, accurate content is a huge, huge part of the challenge. And as you can see on the right-hand side, there's another challenge. Again, we see the start of an online consultation journey that starts with first choose from one of these 93 symptoms. And I don't know if anybody's ever played those memory games as a child where you have to remember all the items on the tray and then they sort of lift the cover it up and you've got to name everything that's on there. I sort of defy anybody to read that list and name it all 93 things on there, consider them and then decide which thing is actually the one that might suit them best, because some of that list also includes quite complex jargon, which makes sense from a medical perspective, but is pretty challenging for a lot of people who struggle with literacy and or working in a second language. I always sort of translate and say, well, if you sent me to France tomorrow and said, right, here's 93 different things in French, you've got to try and understand which one it is you have today. That would be an almost impossible task. So it's really important. And again, the really good news is we have content guidelines for that. We have both a style guide teaching us how to write really well and to structure really well, particularly so accessibility software can represent the page well to people using that software, but also a really brilliant, very down-to-earth language guide that really makes our communication very clear for lots of people. So if there was a second thing I'd really want to draw people's attention to is the real importance of well-written, simple, straightforward, very plain English, and as few words as possible wherever possible. So that then sort of covers it in the next slide in terms of the guide is there. The other thing I'd also draw your attention to is there is a brilliant app, the Hemingway app, for those that haven't used it, where you can put any piece of copy you like into it and it will tell you the reading age. The NHS has a target reading age of 9 to 11, but actually the vast majority of content that we've seen and tested doesn't meet that. It's too complicated. So being able to do that and learn what good looks like that is a really important part of any content creation. And we have a huge amount of content creators across primary care. So the more we can support and educate people about the importance of that, we can really radically improve the journey. So moving on to the sort of last section, we then also looked specifically at the challenge of finding and completing online consultation forms. You can see from the amount of red in this chart, it was significantly more challenging than the sort of more familiar tasks. And there's some really good reasons for that, which I want to sort of dig into for a moment, but this is a particularly challenging task for some quite interesting reasons. The first is the term online consultation, when we tested, doesn't mean very much to people. So therefore, how and when you should use or look for an online consultation form is not very, very clear. And then, as we were talking about right at the beginning, what I should be looking for in terms of knowing where that might be and how that might be labelled is really difficult. And so what we find is people going, well, what I really want is an appointment, so I'll just keep hunting for appointments. And quite often they reach for sections that have appointments information and the other ways that you can reach for an appointment from your practice. And that information about online consultation forms isn't there. It isn't co-located with that. And they also see a lot of different brand names. They also see a lot of different terminology used, some of which is very, very similar and very confusing to patients. So there's a very simple recommendation that we've tested and then made on the back of that research, which is using the phrase request an appointment online. So and being very, very clear that that's what that is. It's a tool to request an appointment, and therefore integrate that alongside the other options that you have. So whether that's phone or being able to walk into the practice, any other ways that you might want to communicate with the practice and ask for support, and then really make sure that we talk about appointment and include the word appointment within that phraseology and the sort of stepping stones that I was talking about to an appointments page, which has all of those options laid out in front of them. And when you do that, suddenly it unlocks those in a very, very different way for patients. It gives them it gives patients basically a choice of options with clarity about which ones are useful for which particular things, or if there's any restrictions or any particular mode of contact that suits their particular need for urgent appointment or routine appointment at any one particular time. And we have standard copy that we've tested to help with that. So we've got standard copy, which we're encouraging practices to use. What we try to do is help support content creation. We have 3 different pieces of work: the appointments, which is in the existing guidance. There's also a recommended copy for prescriptions pages and for contact us, and that's really to sort of take some of the pain out of creating that, so it's really straightforward, that people can then pick that up and adapt it to local circumstances as they wish. And we're always really happy to help advise and support if people need anything that they want to query, or they want to add stuff, or they think there's some other need that's been missed. So we're always welcome feedback on all of these areas. And so just to round off, what we found is this is a couple of good examples of where we have something that says appointments at the top, e-consultations only a couple of steps below on the mobile scroll. And what we found is almost everybody goes straight to the appointments in that page, because e-consultations wasn't a phrase that really resonated or understood what we're doing. So I'll stick with what I know, and I'll stick with what I think will get a result. So unsurprisingly, most people then went for that first option. And then unfortunately, because there is no information about the online consultation forms, they weren't able to start the task in that particular instance. Whereas the contrast between this, where we have a similar challenge, which we would try and iron out, there's 2 pieces in there: that's get help and advice online and book an appointment. So people were sort of hovered and debated in their mind which one of those was more appropriate to their need. But the really good thing about this particular piece of design is both places have relevant information and starting points for that. So it didn't matter as a user, you'll get to what you need to get to through both of those routes, although we would recommend in an ideal world bringing both of those things together. So very, very small details can make a massive difference to the ease of use. And I think once you understand the intent that people have, the keywords and the behaviors, it's really easy to start putting together a really good journey. It's not difficult, it's not impossible, if you understand and have access to those key bits of information, and really small things can make a radical difference. The one thing I'd then like to sort of round off with is around accessibility. I think accessibility is a more tricky field for many people, because it's not able to see it quite as visually as some of the usability issues. And so we tested the accessibility of these journeys to OC and whether they met the legal standard, which is WCAG AA, and almost all of them didn't, and there's a really and so 9 out of 10 didn't, and a really wide variation in compliance. And so I'd really urge anybody who is thinking about sort of updating or improving journeys to reach out for expert support, and we use various testing agencies who are expert in this particular area to help do that. We've worked with suppliers to encourage them to improve their core templates, but it's also important to remember lots of the content that we load into these templates from suppliers also affects accessibility. So for example, we see lots of images which might have really important information for patients that aren't tagged appropriately. So the software can't read that image and explain it to a user who can't see that image, for example. So there's lots of really important nuance in that it's really helpful to have people alongside you who are expert in those areas, who can help support and deliver really good design. So I'm going to hand back to Minal just to sort of finish off on then how can we make the journey to improvement as easy and straightforward as possible.
Thanks, Dom. So hopefully you found those findings interesting, and I think it's probably no surprise to anybody that has accessed a GP website that it's not easy to use. But I think this starts to put evidence behind why and also starts to recommend some very practical improvements so we can progress better usability and accessibility of websites. And so what are we doing to support that improvement? So foundations, we have great foundations already. We've got the design standards in the NHS Digital Service Manual and the content style guide that really supports with that language and the content. And we are now starting to really help suppliers implement that more systematically into their templates. We have codified good practice around GP websites, and I think it's really important to emphasize it's evidence-based, it's been tested with users, and we've published national guidance based on this, and Dom presented some of the templates and tested copies. We're trying to make it as easy as possible. We know that we can't drive transformation through guidelines, so it's setting out what good looks like and best practice, and trying to develop tools now to make it as easy as possible to implement. So really, it's been really great to see actually the response from the majority of suppliers. They have welcomed the guidance and they have adopted a lot of the guidance into their product. And some of the latest GP website templates incorporate the recommendations and are starting to converge on the NHS design standards. And just as a couple of examples, we're seeing removal of pop-ups and overlays, as Dom discussed at the beginning, those critical tasks for patients that are now included in the homepage on quick links, as shown by the example on make, change or cancel an appointment. Primary navigation, as Dom presented, the items in the menu include clear sections called appointments, prescriptions, contact us, to support patients on the most critical journeys that they visit the practice website for. There's clearer labelling of menu icons to support the 3 ways that patients find and start key tasks. There is a convergence in towards the design standards and having a more consistent look and feel, which aligns with the NHS. So patients aren't having to learn how to use digital tools every time they use a new one. So that's really exciting, I think, that we're already seeing progress in this space. We're also beta testing a web audit tool that we've developed to help practices and PCNs, federations, ICSs at varying levels of the system to identify specific issues and fix them. So taking a very much a data-driven approach to improvement, to identify the priority areas of for improvement, and then focusing energy and time to fix those, and compare sites and track that improvement going forward. So embedding that continuous improvement approach. And then thinking more widely about change. This is complex change, and we need to embed capability at every level of the organisation. So we're working closely with ICBs to enhance their capability and skills in audit, strategy, delivery and measurement of this. We have invested in digital and transformation leads as part of the additional role schemes for PCNs. We have created a bespoke training programme for them nationally that combines quality improvement with digital transformation skills, and we're then going to be supporting them with mentoring and training for up to a year to really help them implement that theory and that learning into on-the-ground operational practice. And then more broadly, we're embedding a systematic approach to continuous improvement in general practice. And we're working with ICBs to take a much more systematic approach to understanding the support needs of their general practices, understanding where they are in their improvement journey, the starting point, having a tiered approach to the type of support that they need and matching support to needs, recognising that there isn't a one-size-fits-all. Building capability, embedding peer ambassadors back into structures to really drive that transformation, to start really focusing on building those local peer communities, using that data and relationships to start to drive that shared learning and challenge, and then taking that multi-dimensional approach to one of the hardest problems, which is to try and create time and headspace for local leaders to then drive forwards with the improvement. So final slide, this is how you can access the resources that we've discussed. NHS England website for our guidance. We are shortly also going to be publishing the web audit tool so that you'll be able to access that too. And hopefully very soon on the NHS Futures website, we will be publishing our usability framework. So our testing scripts, our sampling frameworks, etc., to make usability testing as easy as possible as well. We see this as a very much an iterative approach. You know, it's not done. We're continually learning, adapting, and improving the guidance. So again, we're really keen to hear your feedback, but also we're really keen to support and work with anybody that's looking to make change in this space, to help you do this and do it well. So thank you.
I'm back on, I hope. Thank you so much, both. That was really, really good. I think Vijay was looking at some of the questions and was going to present them back to you. So hopefully, Vijay, have you got any of you picked up?
Yes, there's a few. Some of the questions have been answered by Dr. Bakhai, so thank you very much for that. But there's a few other questions which I have, which I'll just go through. One person said they want to know who temp provider is. That was the good one, I think. And it kind of goes on from, he said 90% were not fully compliant. But the same slide says all suppliers are required to be compliant with the WCAG AA standards. But slide 27 said suppliers have adopted the guidance and the latest GP websites incorporate the recommendations. So also the question is, does this mean there's no longer an issue with usability and accessibility? I don't know if you can answer that.
I can answer the specific accessibility question. So the WCAG AA guidance is the accessibility standard that all public sector websites should meet, including all of ours. The challenges on the particular journeys that we tested, as I said, 9 out of 10 didn't meet them in full, but there's a varying level of reasons across the different templates as to why. I think the two things to bear in mind is the template is part of the challenge, and some of those issues are with the templates, and this testing was done about 9-10 months ago, so the suppliers have been working on addressing the issues that have come up with that. But accessibility is also driven by the content that's loaded into them by practices or supplied by ICSs to practices or other parts of the NHS. So it's a joint effort in terms of making sure things are fully accessible. And therefore the accessibility can reflect challenges in the template, or it can reflect challenge in the content, or a combination of both. So therefore, you know, it is important that people reflect on that and address those. The other thing to address usability in parallel to that is the web audit tool then absolutely does the similar type of thing, where it then looks at challenges within the template that a practice could ask a supplier to address on their behalf, and then also the challenges that are to do with content that's usually more within the practice control. So you can obviously bring both teams together to then solve the overall challenge, and then increase the usability of those particular sites or journeys.
Great, that's really helpful. There's one question, do you look at the difference between computing literacy and computing accessibility? I suppose one further thing on this was that 30% of the population you described as low to moderate digital confidence. I'm not sure what tool was used, but does it distinguish from the least digitally confident and potentially very digitally confident, but with English as the second language?
Yeah, absolutely. It's a really good point, and it's a very complex area. But digital confidence generally is a mixture of three broad elements. So one is about access to digital. So many people have challenges with that. The second is about the skills to then sort of access that, and then also the motivation. And motivation, I think, is really underrated. So it's amazing what people have managed to do, particularly if you listen to patient stories through COVID, people who were very disenfranchised in some cases, during COVID have reached for tools and done extraordinary things to do that, because it was so important to maintain connections or access to services or whatever it happens to be. And then absolutely on the other side is the sort of usability or the accessibility of the journeys that they're doing. So there's a really complex set of interactions which are very, very different for different kinds of people. And Ofcom, if anybody's particularly interested in this area, we can happily jump on a call separately, but Ofcom have done some really good research, and it's the only sort of national pieces that we've seen that are consistent over time into those areas, and some of the sort of progress that's been made in that. But again, so the language thing is very particular, so that's why we try and encourage people to think both about language in terms of general literacy, as I was briefly touching upon, which is a huge challenge across a vast number of patients, and very variable, because obviously most people are, if they're used to phoning and interacting with the healthcare service, they might have very amazing verbal skills and verbal confidence. But we've literally sit in testing where people will tell us for 10 minutes what they called the practice about last week, and then they'll write 3 words into a digital form. And you sort of say, well, why is that? And people say, well, I'm not very good at spelling and I don't feel very confident about that. And because it's going to a doctor, that's quite a formal thing. So I don't want the doctor to see I can't spell certain things. And nobody, by the way, can spell diarrhea. I mean, me included. It's always the one that trips everybody up. But a joke, but it's a really important piece, because how people feel about that experience, it feels like being in school, and it feels like writing something formal that's going to be judged by someone else. So people can be very cautious in that particular scenario, and therefore not provide as much information as they might in a different communication style. And so we're asking people to move from a verbal to a reading comprehension skill and to a written expressive skill, which is we're not all even in all of our skills. So that's one challenge, and I think that's particularly pertinent then if you're working in a second language, because you then have additional challenges above and beyond that. So again, it can be really complex in terms of people's skills. I did some work for British Council and language teaching, and they measure very precisely in some of the work that they do the different kinds of skills that we have and the interaction between those. And so I think it's not to underestimate the big shift that we're asking people to undertake in many cases, to move from one particular way of communicating to another, and that impacts different people very, very differently.
And I think just on that, on a kind of very practical level, what you see, and I'm sure clinical colleagues on the call will have experienced this, is that you will find that for some people where English is not their first language, this gives them more time to think about their concern, and then to spend more time to articulate that, rather than on the spot when somebody asks them, and they're then having to do a bit of translation in their head, and they don't necessarily get their concern out in quite the way that they would have liked to if they'd had a bit more time. And also, where it's appropriate, they have support from a carer or a relative to help them articulate, particularly if that carer or relative works and can't often accompany them to appointments, for example. So I think what I've learned is that you can't make assumptions, and that it within cohorts with the same perceived challenges that we would perceive as a challenge, they respond to these things in very different ways. So it's being flexible, and giving people choice, rather than forcing people to use a particular route of contact.
That's a really comprehensive reply. Thank you very much for that. Miriam, have we got any more time, or shall we?
I think we've got, according to my clock, we've got 5 minutes. So have we got another question, or can I ask one?
You can ask one, I think.
So we've got, and I think we've got a number on the call as well. We've got digital transformation leads. So I was just wondering, do you see it as part of, I was inferring from what you were saying that you see it as part of their role to kind of get involved in this. So this is the way that we're going to adjust some of this. Is that correct?
Yes, I think this is a real key role for the digital transformation leads, but we're really keen to support them. So there's a kind of open offer to any digital and transformation lead that we are setting up, and we'll be launching a training program, but also to be able to share some of the nuances in this research, help them implement that, help them use the tools and implement the tools that we've developed, but also, as I said, provide that mentoring and coaching, because there's something about training and hearing about it and doing it in theory, and then you're going back to your PCN and having to do it in practice, and you might be like, oh, what did they say? But also, actually, how does it translate? So we're trying to help do that translation piece from knowledge to action and really make it quite practical and hands-on support, as well as the kind of the knowledge sharing.
That's brilliant. I think that would be a great. There's already people saying, can I join? Can I get access to that? Because I think that would be a great help. Because the other question I had, and sorry, I'm suddenly taking over. It's like being given the pen. Is around, you did an audit at your practice and you were able to see that a number of people had normal results, so that suggests then you can do something to, in a way, drive them away from the phone and give them an easier access route for those of them, people that can use it. Will you be providing some other guidance, for people to help them with doing similar sort of audits? Because I can imagine there'll be a lot of people trying to chase their referrals, for example.
Yes. So I think this is comes down to my last point about this is part of a wider approach to embed continuous improvement and data-driven improvement. So helping practices understand their routine operational data, the demand, the types of demand, the contacts that are being made, so they can start to then be able to prioritize where do they focus their energy and efforts, because we only all have limited bandwidth. Where is it best to focus on? Where do we start to be able to do that? But then also it's about the data itself doesn't result in a change. So we need data, we need leadership within at every level. We need then the improvement support or the capability to do that. And then we need the alignment and the tools that make that simpler, easier, or enhance the benefit. And I think that's the approach that we are taking more widely across primary care, and websites is one example of an intervention.
Okay, that's wonderful. I'm sure that's really helpful for people here. So there's, I think we're just out of time. So if I can just share my screen one more time, if that's all right. I have to thank Minal and Dominic very much, because I personally, this is an area that I'm particularly passionate about, because I completely concur in terms of what you're suggesting. And I genuinely think it'll have an impact on demand to the phone. If we can, for those who can use it, if we can direct people in the appropriate way and provide them with the right information. I've got loads of examples from a very unscientific view that I did of people's websites, but I won't share those now. So I've just got to thank you all both again very much for doing that. Hopefully there's a slide up here that people can actually see, which I've put to say thank you for your participation and for attending tonight. And also can you actually see that slide, or is it covered over by the various bits of chat windows? You can, okay. So Minal has kindly said that she will do another webinar with us probably early summer. We're just working on dates around technology-enabled change. So what I would be interested to is, if you're interested in hearing about that or other things that we as a BCS Primary Healthcare Specialist Group are doing, then there's various contact mechanisms on there. And there's a QR code on to join our non-member mailing list, and we'll let you know about that and anything else. Just to confirm, we will be sending out a link to the video. Minal's team have given me a link to the guidance, which I'll put in, and a copy of the slides, which you'll also get afterwards. So hopefully that will cover everything. Any of the people who have come up in the chat and said that they're interested in knowing about the access route, I will talk to Minal about how we get that information to Minal and Dominic. So if you put it in there, I'll try and grab it out. And obviously I've put something in about the BCS as well. So I think without further ado, unless there's something else from anybody else, I'm looking around at the virtual room. Thank you so much for coming today. Thank you again, Minal and Dominic. It's a really interesting, fascinating talk from, and I'm sure thank you from everybody in attendance as well.
Thank you for having us.
You're welcome. Good evening. Cheers. Bye.